Thank you for inviting me to give you a talk on systemic therapy in elderly and PS2 patients. Actually, you have learned a lot during these 2 days about the systemic therapy in unselected population of patients, but as you know, we have specific populations. Not all the patients are, I'm sorry, what's
it's the green button?
The green one, okay. Sorry. Not all the patients are equal, and we need to take this into consideration when we are treating our patients. Here is my disclosure form. So when we are treating the patients, we need to take into the mind always that really not all the patients are created equally, and not all the patients should or could be treated equally. When we are talking about the targeted therapy, maybe the situation could be different. When we have a well-defined target and very effective targeted therapy, then we don't have so many concerns about the toxicity, because every efficacy of the effectiveness of any treatment is actually composed from the efficacy and toxicity. So we need to take care about the toxicity, and at the point of the toxicity, we embark on the field of the frail patients, namely elderly patients and performance 2 patients. There are very few data on the effectiveness of systemic therapy in elderly and performance 2 patients. As you know, a few years ago, till 10 years ago, there were major limitations in the enrollment criteria regarding the age of the patients. Now it's changed. We are allowed to put into studies also elderly patients, but there are still limitations regarding the performance status. Mostly in most of the studies, exclusion criteria exclude patients which are frail with such comorbidities, patients with not adequate liver or kidney function or whatever. So there is really a representative collective of the patients in the trials. On the other hand, we have some trials dedicated to elderly or performance 2 patients, and based on these trials, we built our recommendations. And as you can see here, the recommendations, the ESMO recommendations that we have issued a few months ago, actually mirrors what we already discussed, which is the fact that the patients with the targets, oncogenic drivers, and actually in these patients, in terms of the targeted therapy, we do not need to select the treatment according to the performance status or the age. But on the other hand, for the chemotherapy, first or second line therapy, the guidelines are separated, are different according to the age. We separate between elderly, non-elderly, and performance status. These recommendations are based actually on the evidence-based data, the trials we have. And during the next 15 minutes, we will go through this data, and we will discuss what evidence-based data do we have for chemotherapy in advanced non-small cell lung cancer and adjuvant chemotherapy for elderly and performance 2 patients. What data do we have for targeted therapy, namely for EGFR and ALK targeted therapy, which are supposed to be standard in more or less all of our countries in Europe nowadays, and what do we know about the immunotherapy, the new therapy for this collective of patients. What about chemotherapy for advanced disease? You all know very well this data. This was the first meta-analysis, not the first, but the second meta-analysis about the value of the chemotherapy compared to best supportive care in advanced all-comers of non-small cell lung cancer patients. Here you can see that the patients with older than 70 years, as well as the patients with a worse performance status, more than 2, performed equally well as younger patients or patients with better performance status. Chemotherapy improves survival equally in patients with higher performance status or the elderly patients. Likewise in younger or patients with performance status 0 or 1. But of note, in this meta-analysis, chemotherapeutic schemas with platinum as well as monochemotherapy was included. When we embarked on platinum-based doublets, and also in this meta-analysis of the platinum-based doublet, you can see that there were some concerns about the toxicity. And in this particular Schiller trial, comparing 4 different schemas, at the beginning, also patients with the performance 2 status were included. But after including 66 patients, the monitoring committee decided to stop the accrual for performance 2 patients. This is a very important information because the toxicity for patients with higher performance was higher. And that's why we still have concerns about the safety and, of course, at the end of the day, effectiveness of platinum doublets in patients with performance status 2. After that, some individual trials have been performed in patients with performance status 2, comparing single-agent chemotherapy versus combined chemotherapy. The meta-analysis of these trials, in these trials, the platinum-based chemotherapy schedules, doublets, and non-platinum-based doublets, namely in MILE study, have been included. If you read this slide, you can see that in the meta-analysis, the platinum-based doublets performed better, resulted in better survival compared to the monochemotherapy, while it does not stand for the non-platinum doublets for this collective of performance 2 patients. However, the toxicity was higher. Especially the toxicity in terms of myelotoxicity was higher in the doublets as expected. Based on this meta-analysis, we can conclude and we can learn that platinum doublets are superior in terms of response rate, progression-free survival, and overall survival with hazard ratio of 0.71 in performance 2 patients, but there is a substantial rate of toxicity we need to bear in mind always when we are thinking about the combined platinum-based chemotherapy in performance 2 patients. Here are some of the most important individual trials included into this meta-analysis. What I would like to point your attention to are these 4 trials I have marked with green or yellow, the combined, the platinum-based doublet. The positive trials are mainly coming from the doublets combining carboplatinum plus Pemetrexed or Paclitaxel with a carboplatinum AUC 5 to 6. And then there is one trial I would like to point your attention. This is the French trial, Soria and Chevalier trial, in which cisplatin 120 milligrams per square meter was used. Not surprisingly, this trial was highly negative trial in terms of overall survival benefit in performance to patients. It's quite toxic. I would never dare to give such a dose of cisplatin in performance 2. Even performance 0 or 1 could be very tricky. So overall, in performance 2 status, we have data now that for patients, some patients, we can use carboplatin Paclitaxel or carboplatin Pemetrexed schema. If you look at these 2 particular trials, the first one using carbopem and the second one carbopacli, you can see that the benefit was substantial for the whole collective of performance 2 patients. Also here we are now embarking, we are coming closely to elderly patients. The subset analysis of these particular trials in more than 70 years patients was positive, as well as in the whole collective of performance 2 patients. So even in elderly performance 2 patients, this particular trial was positive. But again, please read the bottom lines. There are concerns about toxicity. In the combined arm, there were 4 treatment-related deaths related to sepsis, pneumonia, thrombocytopenia. So you need to be cautious about the toxicity in these patients. The next trial, which was positive in elderly and in performance 2 patients, was the trial which was actually designed for elderly patients, French trial. You know this trial very well, Carbo Pacli versus single agent. Please note that the single agent was not Pacli. The single agent was something different, Vinorelbine, Gemcitabine. That could be a criticism of this trial, but anyhow, highly positive trial, significantly better overall survival with the combined schema. Again, also for performance status 2 patients, the same benefit. But again, toxicity might be a concern. This is something you need to be cautious always. Again, 4% of the treatment-related deaths in the combined chemotherapy schema. In elderly patients, now we are coming to the elderly patients. In elderly patients, there were quite a few individual trials comparing best supportive care to monotherapy. The most important is the first one, Elvis trial, which confirmed the benefit in terms of overall survival with chemotherapy, monochemotherapy, Vinorelbine namely, compared to the best supportive care. And then you have the list of the, from my point of view, the most important trials comparing combined chemotherapy to monochemotherapy. As you can see, also in more than 70 years old patients, the combination two drugs, non-platinum combining drugs, are not better than monochemotherapy. On the other side, like in the performance status 2, platinum combinations, namely carboplatin combination, is better than monochemotherapy. So more or less the same story for elderly and for the performance status 2 patients. In the elderly patients, for the elderly also a meta-analysis has been performed. In this meta-analysis, the results are quite dispensed. But for platinum doublets, more or less, we can see that maybe doublets could be favored, but again, on the cost of the toxicity. To conclude, doublets are better for performance status 2 and elderly patients, but the toxicity is still a concern. How to improve the selection of the patients, especially in elderly? We have some tools, and the most known and used tools is comprehensive geriatric assessment. It is quite time-consuming. It is very difficult if you don't have a geriatrician at your team to do a complete geriatric assessment. But the comprehensive geriatric assessment would help you to define a physiological age, because what is important is physiological age and the fitness of your elderly patient, not the chronological age. And what is very important to help you to figure out what is the biological, physiological age of your patients you are treating in your everyday practice is to think about functional status of these patients, performance status, about comorbidities, about cognitive status, emotional status, nutritional status, and also about socio-economical status. Especially in my country, sometimes we are forgetting about the social economical status. In elderly patients, in performance 2 patients, supportive care is very important. And it's not only about supportive care done by oncologists or oncology research nurses or nurses. It's also supportive care which is performed at home. Most of the complications of our treatment are actually patients are experiencing where they are at home. So they need a very good social support, and what is very important to think about. Of course, it's very nice if you have a geriatrician, if you perform geriatric assessment, but you can think about these points, and you can figure out in your individual patient which is fit and which is not fit very well in your clinical practice if you go through all these, let's see, points where you're sitting with your patient and where you are discussing with your patient whether you will go or not for chemotherapy or immunotherapy, not so much targeted therapy. There was one trial in lung cancer according to which patients were allocated to combined therapy, monotherapy, or best supportive care based on the performance status or age, or based on comprehensive geriatric assessment. In this particular study, unfortunately, the overall survival was not better in patients which were allocated to the polychemotherapy or monotherapy based on comprehensive geriatric assessment. But there was less toxicity. So we need to think about the geriatric assessment when you decide about the chemotherapy in your patients. That's about the first-line chemotherapy. What about the maintenance chemotherapy? Maintenance chemotherapy we are using nowadays, more or less the most important from my point of view, is Pemetrexed maintenance chemotherapy in adenocarcinoma patients, first line without targets. So the subset analysis in the PARAMOUNT trial showed that the benefit for elderly patients was the same as for the patients less than 70 years old. Only patients up to performance status 2, 0, and 1 have been included. So we cannot say anything about the performance 2 patients regarding the maintenance, but for elderly, the same benefit, no difference. What about add-on targeted therapy? We are not talking here about the real targeted therapy. We don't have any target. It's only add-on anti-angiogenic therapy. As you have already heard today, in this trial, in a REVEL trial, using ramucirumab, the benefit for elderly was not equal, it was not in favor of ramucirumab. While in terms of the nintedanib, also for the elderly patient, there is a benefit. And there is a benefit regardless of performance status 0 or 1, but we don't have any data for performance status 2, because only patients for 0 and 1 have been included. So why ramucirumab differently for nintedanib? If you are working with these drugs, you may know, or also if you go into the trials, you can see that the toxicity was a little bit different. Nintedanib seems to be a little bit less toxic. Of course, we don't have any comparatory trial, but if you go sit and look at the toxicities in these two trials, you will see that anti-angiogenic inherited toxicity might be a little bit higher with ramucirumab. That could be a reason for these results. So what about adjuvant chemotherapy? Adjuvant chemotherapy subset analysis of the largest LACE meta-analysis has been done according to these subgroups of the ages, and as you can see, the benefit is also seen in the older elderly patients more than 70 years old. There was no interaction between the age and the benefit of adjuvant chemotherapy in the LACE meta-analysis, but only patients up to 75 years have been included. So all the data we have are the data for the patients up to 75 years. For more than 75 years, there are no data about the adjuvant therapy, and only patients with performance status 0 and 1 have been included. So that was chemotherapy. What about EGFR and ALK targeted therapy? That's an easier issue. These therapies are much more efficient than chemotherapy in the selected collective of our lung cancer patients with targeted mutations. 70–80% response rate, much longer progression-free survival. With so effective therapies, there are much less concerns about the toxicity in frail populations. And also the toxicity of EGFR or ALK-targeted therapies is not so low, but it is not we are not talking about life-threatening toxicity, so it's not such a concern. And really, in these trials, there were some very limited subset analysis according to the age and performance status, and only patients up to performance status 2 have been included. That's why I'm not presenting this subset analysis. I think it's much more important to look at this data. Although this trial has been conducted in only 30 patients, it is very illustrative. It's the beauty of the targeted therapy. On the right side, you can see the beauty of the real targeted therapy. For the lung cancer, for a long time, we didn't have a very effective therapy. That's the problem. And here is the beauty. Even in elderly, even in performance status 3 or 4, Here, only patients that were elderly and a poor performance status, only more than 80 years performance status 1 were included. Otherwise, poor performance status more than 70 years, and you can see the same response rate as you can see in the previous 7 pivotal prospective trials, about 70% response rate. Progression-free survival, 6.5 months, very comparable to the collective of younger patients in 7 pivotal trials. And on the right, you can see the improvement in performance status in the majority of the patients, which comes very, very quickly. So in the targeted therapy, which is very effective therapy, there is no selection according to the performance status or according to the age. For targeted therapy, just for illustration, patients up to performance 2 have been included in 2 pivotal profile trials. The benefit is comparable regardless the performance status and regardless the age. Last, what about immunotherapy? Immunotherapy, we have very few data about the effectiveness of immunotherapy in the patients with performance status 2, practically no data. We have data for elderly patients because in these trials of immunotherapy, not a lot, but a substantial percentage of the patients older than 70 years of age have been included. Here are the major trials in the second-line therapy, based on which nowadays we have Nivolumab and Pembrolizumab in a routine clinical practice. And in these trials, patients up to performance 1 have been included. Patients up to 85 years old have been included in these trials. So these modern trials do not have exclusion criteria 70 years old patients. But still in these trials, there are exclusion criteria regarding the multiple comorbidities and other, let's say, organ functions. Subset analysis that has been done in 3 out of these 4 trials revealed that the immunotherapy benefit over Docetaxel was the same regardless the age. In most of these trials, the cutoff was more or less than 75 years old. So more or less the same benefit regardless the age, but no data about the performance to patients. Here is the pivotal trial for in the first-line setting. Again, in this trial performed in the upfront immunotherapy, namely Pembrolizumab versus platinum-based chemotherapy. The subset analysis revealed the same benefit for older patients like for the younger patients. Again, 65 is the border. So, based on this data, maybe I am sure that we can be quite confident to treat also elderly, fit patients with immunotherapy. What about performance status? That is another issue. What we are learning with immunotherapy during the last months or years is that we have a steep decrease in the first 3 months. How to select patients not to harm them with immunotherapy, how to select patients that will really benefit from chemotherapy, because during the first months we can lose our patient. And bad performance status patients, are these the patients that we should be concerned most about immunotherapy? I don't know. We don't have any data, but there are interesting data that were presented by Solange Peters during the last conference in Vienna. She looked at the characteristics of the patients that were alive 3 months after initiation of immunotherapy, namely Nivolumab in the second line, and patients who were not alive at 3 months. And as you can see, even if you have only distinction between performance status 0 and 1, it seems that patients in performance status 1 have less possibility to be alive after 3 months than patients with performance status 0. Maybe there is some signal. Surely there is a signal for a future research and future discussion about how to use immunotherapy in performance status 2 patients. Just to conclude with some real-world data. At my clinic, University Clinic Gulik in Slovenia, we are diagnosing and treating each year about 600 newly diagnosed lung cancer patients. We have established a hospital-based registry in 2010, so we have now data for 5 years. And based on our registry data, these are not randomized data, that's observation, registry, real-world data, you can see on the left side of the panel that according to the age, if we decide to monochemotherapy, that's the pink number, it's completely the same bad survival for patients more or less than 70 years old. If we decide for chemotherapy, platinum-based chemotherapy, blue lines, it's completely the same whether it's less than or more than 70 years. For targeted therapy, the first part of the curve is okay. Then we have a split. The reason we went into this data is that the patients older than 70 years of age didn't receive second-line chemotherapy, and at that time, that's the data for 2010-2015, we didn't have mutant-specific third-generation EGFR TKIs, we didn't have second-generation ALK inhibitors, and elderly patients didn't receive second-line therapy. That's why for elderly, targeted therapy curves are separating after 1 year. On the right side, you have our data for performance status.
Tanya,
yeah.
Can you wrap up a little bit?
Yes, I will. For performance status, you can see that for regardless of the performance status, monochemotherapy is the same, targeted therapy is the same. Platinum-based chemotherapy, there is a distinction. Patients with performance status 2 are doing worse. So here are my take-home messages. You have them on the slide deck. To make it short, chemotherapy improves survival, also in performance status 2 and elderly patients. Platinum-based carboplatinum doublet should be considered in fit elderly and performance 2 patients. Adjuvant chemotherapy is recommended for fit elderly patients and patients up to performance status 1. For more than 75 years, we don't have any information. EGFR ALK targeted therapy is not a problem, should be considered in all patients. Regarding the immunotherapy, we have a few data that for elderly patients it could be a very effective therapy. Regarding the performance status, we don't know how to deal with the patients with performance status 2. We don't have, for the time being, any evidence-based data. So to conclude, decision on systemic therapy should be individualized based on the risk assessment and patient preferences, and what is the most important for patients, elderly patients and performance to status patients, you really need a good supportive care, a good oncologist, a good research nurses, and also a socio-economical environment. Thank you.